Nipro Corporation strives to realize our philosophy of contributing to society through our business. We take pride in creating the finest innovative medical technologies that improve the lives of people. Currently, we face an unprecedented pandemic, the novel coronavirus. To fulfill our responsibility to society, Nipro supports global healthcare needs by providing our innovative products to frontline medical professionals and the public. Our next generation minimized dead space syringes reduce wastage of vaccines, enabling more individuals to gain access to the vaccine. We designed a highly functional respirator mask with low inhalation resistance, high particle capture for efficiency, and easy breathing to ease the operation of medical professionals as well as those in need. Backed by research, our team developed an aerosol disinfectant as an essential added measure to reduce the spread of viruses and bacteria. Our fight to improve global healthcare doesn't end here. We will continue to push the boundaries of medical innovation to provide better healthcare solutions for everyone. Together as one, we will overcome the pandemic and improve global health. Nipro, your partner in healthcare.
Good morning, everybody. We are pleased to welcome the presence of doctors and colleagues in the only training program, Challenges and Opportunities in Infection Control During the COVID-19 Pandemic. This program is jointly organized by Nipro South Vietnam and VT Healthcare and also Nipro Asia to share experiences in infection control to deal with COVID-19 in the ICU for medical staff. CME will be issued if you join enough at least 80% time of the program, and you need to register to get one. Now, about the speaker, I'm very proud to tell you that the professor, the speaker, the first one is Professor Dr. Lê Anh Thư, MD, PhD, the President of Infection Control of Vietnam. The second, Ms. Oraisor Kuet Linh, Deputy Director of Nursing, Khu Tech Kuet Hospital in Singapore. And in NIPRO Corporation, we have the presence of Mr. Suchiya Sego, General Director of NIPRO. Now, Mr. Suchiya will say something for the opening, please. Yes, Mr. Suchiya, please.
Good morning. So, distinguished participants, ladies and gentlemen, I join my colleague welcoming you to our webinar. Big thank you must go to Professor Tu as a moderator and speaker for organizing this timely webinar, as well as Ms. Audrey, our invited speaker from Singapore. We all understand the importance of infection control, especially during endless global pandemic period since February 2020. In this context, this webinar will discuss challenge of infection control during COVID pandemic 2020 and COVID-19 and experience from Singapore ICU hospital. As a supplier, NIPRO has been introducing necessary products to fight against infection, advanced version of safety catheters, economic reusable masks, as well as an innovative aerosol type of disinfectant proved to manage bacteria and coronavirus. I'm confident that you will find new ideas, fresh energy, and novel partnership to improve patient life as well as help caregivers during this session today. So I wish you all a very successful webinar today. Thank you.
Yes, and now we will start the program just some minutes. And now please have some saying from Miss Professor Lê Anh Thư. Yeah, Mr. Please.
Dear distinguished guests, ladies and gentlemen, on behalf of Vietnam Infection Control Society, the co-organizer of this webinar today, I would like to thank you, all of you, to joining us for the webinar sharing experience during the COVID pandemic. As you already know, the COVID pandemic hasn't ended yet after for more than 2 years, and the world has been changed during the pandemic. There's a lot of challenges, but also that there are a lot of opportunity that make our world stronger and more connected. Therefore, today we would like to make an overview of the challenge and the opportunity for infection control during the pandemic of COVID-19, and especially I'm looking forward to have a good chance to get experience sharing from ICU ward from Mr. Ori. So I think that we can enjoy this workshop today, and thank again for joining the webinar, and I wish you all staying safe and healthy. So we will stay to we start the program. Dear Ms. Trinh.
Yes, now is 9:58. So the program we will start now, and the first presentation will be presented by Ms. Thư also, and you please, yeah, Professor Thư.
Yeah, thank you, Ms. Trinh. I will share my screen. I wonder if you can see my slide.
Yes, yes.
And can you see my voice okay? Or?
Yeah, okay.
Yeah.
It's clear, it's clear.
Yeah, yeah. So I will speak in English, and I think that there will be the Vietnamese translation. So I hope that the Vietnamese translation is okay also. I would like to start this workshop today with the overview of the challenges and opportunity of infection control during the COVID-19 pandemic. I will talk about the COVID-19 situation overview, just a brief overview, and then describe the challenges and opportunity of infection control during COVID-19 and the trends required in responding to the COVID-19 pandemic. So as you just briefly to look at the timeline of the COVID-19 history. We remember that on December of 2019, the first 20 cases of strain pneumonia was recognized and reported in Wuhan. And after that, 1 month after the Wuhan market closed, and then CDC had to report the new virus called the coronavirus. And then in January 20, we found the genome of the new coronavirus in Japan. And in the 30th of the January 2020, WHO declared that the outbreak constitutes of the public health emergency of international concern. And after many cases, and in March 2020, WHO declared the pandemic. And until now, we have more than 470 million confirmed cases in the whole world, with more than 6 million people died because of COVID-19. In the Asia country, you can see that we are similar to the other region. We had 4 waves of the COVID pandemic. And now in Asia, in the Southeast Asia, the case still continue to increase. In Vietnam, we had so far 8 million confirmed cases and 14,000, more than 14,000 cases of death. And we just laid back the peak of last week, and now the case seem to be reduced, and we hope that we can have a good change in the future. So let's look at the overview of let's look at the coronavirus. Where is that? So this is the tree of all the virus, and you can see that the coronavirus is in this branch, and we had 4 lineage, A, B, C, and D, and the SARS-CoV is in the B of the coronavirus. And we talk about a lot of variant of concern of SARS-CoV-2. So far, we are in most of the, I don't know in the other country in Asia, but in Vietnam now, 80% is infected by the Omicron. And before we had the Alpha, Beta, Gamma, and Delta, and Omicron. And we had to pass a very difficult time with the Delta variant. But now we are changed to the Omicron, and with the symptom is less severe than the Delta, but more transmission. So now most of the people seem to be infected. So, so how we already respond to COVID-19? Let me look at the global responding to COVID-19. Always we had four phases. The first wave, when the number of cases increased, we call that is the shock and realization phase. And when the number of cases increased, exceed the medical capacity, we had to lock down the country. And after 3 to 8 weeks of lockdown, the country usually go to the stable ramp up and then come to the new normal. And we are now in the new normal. So the new normal, that means the fight against COVID-19 is far from over. and the pandemic hasn't ended yet. So as WHO said. But so that means we need to continue to practice the protective measure, the infection control measure that we like to discuss today. And so during the 2 years, more than 2 years of dealing with the COVID-19, what are the challenges of infection control? The first thing I think that we had the high rate of transmission. The RO about more than 5 now. So infection control, we need to focus not only in the hospital, but we have to focus also in the community. And we had to have a strategy, the medical chain, depending on the progress of the pandemic. So the infection control policy should be published very frequently, and it should be updated frequently. So even with the vaccination program or the spring clean triage or the environment management policy. And we also dealing with the problem that many healthcare workers had to expose. And also we're dealing with the high demand of PPE. And the last thing that we just discussed recently that is there is an increased incidence of hospital-acquired infection during the COVID-19 pandemic. We look at the strategy of life during the pandemic of COVID-19. We can see that the category had to change. In the first phase, we conduct containment strategy. So every case should be screening, we do the early training and retention every individual case. But when the pandemic becomes very severe, when the number of cases is too large out of the containment strategy, we need to come to the mitigation strategy. That means we need to enhancing the infection control, like social distancing, and then the hybrid is to the lockdown of the cases. So if why we need to take the prevention and control the strategy for COVID, and infection control is very important, because if we don't do anything, we can see that the enemy, the epidemic will come very high like that, and will exceed the medical capacity. And that's why there will be a lot of cases of mortality. So with the measure, we can reduce, we can flatten the epidemic curve, and we can reduce the impact of the pandemic. I just told that about the healthcare workers as well. We know that there are many publics talk about how many healthcare workers infected and how many killed, but so far I think there's no exact number. And there's in last year in PAHO website, they report that at least more than 500,000 healthcare workers and killed to more than 2,500 in the America. And after that, so some people claim that more than 2,000 healthcare workers. So, but the exact number we haven't now yet. But we can see that there in the study, they said that in more than 300,000 in the frontline healthcare worker, and they said that they found that about 1 to 32% of healthcare workers infected with SARS-CoV-2, and with 29% with no symptoms. So in the healthcare worker in the COVID hospital, the average infected is about 9.8%. So compared with the community, the frontline healthcare worker increase the risk of COVID-19 about 10 times more. And the risk is more severe. So this is the always the intensive case is called the high risk for the patient, for the healthcare workers. And we also got the challenge in the PPE supply and use. At the beginning of the pandemic, we had a long discussion regarding the indication of wearing masks and other PPE before the pandemic, mask is required for sick person only. And after that, we decide to mask is required for all. And then we also discuss how and when PPE used. We also discuss in the quality of the PPE because the quality is also important to protect the healthcare worker. And with the using of PPE, we face with the very big problem that we have to meet the high volume of PPE use, and this increase the cost of medical operation. And the nurse, one nurse, Miss Amber Wood, she also said in the presentation, and she very worried that they said the key lesson is that nursing can be effective only when the basic physiology and safety needs are met. So she very worried about the PPE because dealing with in the habit, the PPE is lack, and the reuse and the decontamination of single-use PPE that's called the risk for the nurse, and then it's very necessary to have enough the PPE to use for the healthcare worker. And another challenging, and I already talked about, is the healthcare associated infection in COVID-19 patients. This one, I don't know if in the ICU we can go, but in Vietnam and also in many countries, we found that there's the increase of healthcare associated infection in COVID-19 patients. A retrospective single-center case control study, including 114 patients with severe COVID-19 admitted to the ICU, and they found that 40% developed a bacterial for fungal hospital infection during ICU stay. And then it's this mostly the primary and catheter related BSI, and then pneumonia and UTI. And mostly gram positive 50%, 30% is gram negative, and 50% is due to the fungi. The overall ICU mortality was 36%. So the infection was significantly associated with the death. So sometimes the patient come with the COVID-19 come to the ICU, they didn't die because of COVID-19, but they died because of this healthcare associated infection. And the infection were significantly increased the death by about 2.75 times. And bacterial fungal nosocomial infection is a common complication from ICU patients. Another study also found that we had a program with the high resistant pathogen. For example, carbapenem resistant Acinetobacter baumannii syrup caused hospital crisis that linked to the IPC fish. So that means why we had a hospital crisis in COVID-19, because of the infection control risk. New Jersey hospital reported a cluster of 34 cases that peaked during the surge in COVID-19 hospital relation. So the graph traces the degree when we come to the normal operation risk. So when we return to the normal operation, when we continue to focus on practice, on the best practice on infection control, maintaining the best practice is very important to mitigate the spread. So during taking care of the COVID-19, there's some infection control practice it reached, and we need to change that. And you can see in this figure, you can see here that is the mortality increase and the number of hospital infection increase. And they found that because of the problem of the infection control. The last one, the challenging, is the anti-vax movement. We all know that vaccination is one of the most important epidemic prevention and control measures. But the anti-vax societal manual also occur everywhere. 400 anti-rectal medical account container 58 million followers based in the US, UK, Canada, and Australia. So you can see that in some country, the number of vaccination cover is still low. For example, from this statistic, only in Hong Kong, in only 72%, Singapore is very high, 90%, and New Zealand for like 78%. In Vietnam now, we try to cover about 80%. So that's the challenging, but we still had many opportunity of infection control during the COVID-19. So many people ask me, is there any positive change emerging through the COVID-19? So I think yes. So what is the positive change during the COVID-19? The first thing I can see very clearly that infection control mindset established with the better infection control compliance. Many people know about infection control better than before. For example, the hand wash. They say that people talk about the coronavirus hand washing effect. For example, in the America, they found that 80% of Americans are now washing their hands at least 6 times a day. That before they know. 20% of those Americans are washing their hands 14 times a day. And in the hospital, every year we doing the campaign for the hand hygiene, and we give many message for the doctor, for the nurse to clean hand by using the message like 5 antibiotic resistant or clean hand for all is in your hands, or etc. But the hand hygiene compliance rate is still around 50%. But now with the COVID-19, it came to at least 70% now. So in many hospitals in Vietnam now, we had more than 95% compliance with the hand hygiene. So that is a very good one. And you can see from this study, they found that the trend of the hospital-acquired infection and hand hygiene compliance before and after COVID, and the hand hygiene is increased. With the increase of hand hygiene, they found that they can reduce the hospital-acquired infection. However, they can, with the study also analyze that more people still do the hand washing to rotate themselves than to rotate the patient. So more people like to wash hand after contact patient than before the contact patient. For the mask use, so they also found out if many people wear masks with the high adherence of wearing masks, we can contain the transmission. We can contain the transmission. So now we can see that every people now wearing masks now, and to help to contain the measure. So all of the challenges and the opportunity come to, we can see that there are a lot of change required in responding to COVID-19. So the first thing that we need to enhance the awareness and the compliance about the prevention and control of infection. We had we had the opportunity that people now are aware a lot of the prevention and aware about the infection control. But from the awareness to the compliance to the practice, still the big gap. Many people know that infection control is important, but to practice the infection control, they still forget. So that called like behavior change. So why they still not compliant? So the reason for non-compliance are related to the psychology barrier, the reconciliation notion, cultural illusion, and effective time management rather than lack of a vital result of knowledge. So that's why we need to continue to keep the patient change the people belief. So we need to make the healthcare worker will see the patient safety and clinical outcome as the primary motivation to increase compliance and reduce crime. And we need to tell people that the infection control is their personality responsibility, so that they can increase the compliance. And leadership engagement and data-driven intervention is also very important. But however, we need to think about the necessary condition to create an infection control mindset, that the facility should be available. So that means the PPE, the hand washing, everything should be available. And then the education, we need to improve the education, continuous educate the people. And we need to make the environment to support the infection control compliance. So after we can have all three conditions, we can increase the ability for infection control behavior. So when all the conditions are set at the same time, same place, and we can increase the ability of lion and maintain the infection control behavior. So to reduce the transmission. So that means, and we need to think education, to read the policy, we need to do the monitoring and continue to enforce the people for comply to the infection control. The people we need to pay also more attention in how to tell the people to using the PPE. For example, the mask, the mask when using the mask, we need to focus on the quality of the mask. We have medical mask and high efficiency air mask. We need to think about the quality, and people need to teach them about the method of wearing, because people still do not know exactly the best way to wear the mask. So for example, this is the poster that we explain how to wear the mask and how appropriately. And there is also the shift in mindset toward exploring to the telemedicine, video conference, and AI. During the pandemic, we also think that everything between them become online. Yeah. So alternative technology-based preventive measure may empower the healthcare sector in the long term and enhance the social distancing. So therefore, we need to improve. We need to invest more on the telemedicine, on the video conference, and also we need to invest for artificial intelligence. Another thing that we need to think is that how to during the COVID-19, people know that the open design is refer the closed design in the hospital to minimize the risk of transmission. So many discussions say that the COVID-19 will change the future hospital design. Before, the hospital is designed only one building and very like like the closed design. But now, change to the open design with the focus more on the patient flow, the movement, the touch-free. So this will be more flexible space with open air, with separate building. Also, when we all know about the 3P, like test, trace, and treat, right? But in every phase of the dynamic, we need to know when we make that priority. For example, at the moment, we don't trace the person anymore. We focus on the treat the patient, and the test we accept the rapid test and consider it similar to the BCR. Before we just based on the BCR, now we would based on the rapid test also. And also for the test, we also need to ensure that timely test results are available to guide the exit. That means we need to right infrastructure, right population, and right test and right intervention and right action. The 5 rights that will help to reduce the mobility, mortality, and the disease rate. For the enrichment, also the training enrichment operation. They think about the effective ways of minimizing the impact of COVID-19 on daily medical operation. We think about the innovation in medical techniques like telemedicine, like multi-stage emergency, and establish a medical resource allocation method to balance the needs of COVID-19 prevention and control with the daily demand of medical care. Before, every COVID-19 is in a hospital, but now, as you already agree with me, that most of the COVID-19 will be managed at home. So when we manage the patient COVID-19 at home, we need to enhance the role of the local medical center. The local medical center had to recording the patient need, during the patient checkup, and early discover the symptom of the COVID-19 and to discover the severe COVID to receive GA and so transfer to the hospital on time. And they need to follow the guide of infection control and the consult of the people at home for the treatment, for the nutrition, for the psychologists, etc. So the local medical center at home it will be very important during the COVID-19 as well. And also in the chapter of each specialist, the COVID-19 is added. I found out every specialist now they had their own chapter for prevention of COVID-19 and treatment of COVID-19, and infection control we also added in each the specialist like that, and it's very, I think it's very important because some when the patient with the COVID-19, there's some people with the underlying disease and they need to change the treatment or something, and they need to think about the prevention, infection control in these patients. So this is very important. And the tertiary also is very important because we know that this one is based on the patient, because the COVID-19 is usually transmitting by the contact and by the contact and droplet and airborne, and now therefore the tertiary is very important. For the healthcare worker management, we need to base on the risk level, actual need, and the effect of epidemic prevention and control. We need to think about the epidemiology data, the current requirement, the risk assessment, the effectiveness of IBC measure, and therefore every healthcare worker to define their risk assessment, to define if they had a high risk or low risk. If they had a high risk, they can conduct, they might rest infected, but if low risk, they can continue to work as usual. We also need to promote the vaccination because to change the anti-vax movement, we need to do the censorship and the platforming, like to improve the situation. And the role of government, like providing clear, consistent, regular, vacant, and accessible public health messaging is important. And also need to make visible to the public about the benefit of vaccination. So to conclude my presentation today, and let's have some summary. So the COVID-19 pandemic is still challenging in infection control, but also give opportunity to gain better effectiveness of prevention and control the pandemic. So, and the need for changing the mindset and the behavior for optimal infection control. And we also requirement of innovation on infection, on diagnosis, on treatment, and also for infection control. We need to supply necessary knowledge, audit, and feedback, and ensuring infection control facility and supporting environment to maintain the optimal infection control. We also need to think about the long-term plan and strategy for prevention the COVID-19 to continue. So that's it all of my presentation today, and thank you very much for your listening.
Thank you, Professor Lê Anh Thư. Yes, and we will continue the program with the presentation of Ms. Orisol Huetling. And now, you please say something about you, and also, and after that, you will start your presentation. Yes, Ms. Orisol, please. Thank you.
Thank you very much to the organizing committee and to the chairperson. I'm very pleased to be present at this webinar, and thank you so much for the invitation as well. So just for some background about myself, I'm the Deputy Director of Nursing. I'm a nurse by training. So I'm a nurse administrator at Khoo Teck Puat Hospital, one of the acute general hospital in Singapore. Area of coverage include to provide an oversight of intensive care unit, infection control practices as well, renal dialysis, plus nursing informatics over at my hospital. All right, so without further ado, allow me to share my presentation. And I have plenty of pictures in my sharing here. I hope to give you an overview of an experience from a Singapore hospital ICU. All right. A little bit about the Singapore healthcare system. Where I'm currently working, we are part of the National Healthcare Group, Khoo Teck Puat Hospital. And you can see from the slides, Singapore is divided into 3 main clusters: Central, West, and the East. Yeah, so NSG, KTPH, Khoo Teck Puat Hospital is part of the NSG healthcare group. So Yishun Health in our hospital campus, KTPH is an acute hospital here. Next to us is a step-down care of Yishun Community Hospital. And not far from us, we have an Admiralty Medical Center as well, where we conduct day surgery cases, eye cases, and this is not a 24/7 facility. This is an office hour operating facility. Whereas our main hospital, which is KTPH, and our community hospital, these are 24/7 hospital facility. And you can see from this diagram, the acute hospital and the community hospital are in fact connected, so that this facilitates us to move our patients from acute care to step-down care, and also vice versa as well. This is a snap picture of the entrance of the hospital, just to bring you all virtually to the tour, so that you can have a feel of the environment that we have over at KTPH. I would say that we have a very greenery environment, and this definitely is therapeutic, and we will facilitate a healing environment within the hospital, both for patients and also therapeutic for staff as well. Okay, this is another snapshot. Okay, the outline of my sharing today, I will be covering ICU design, which I think is very important to facilitate care and processes, and also to infection control practices as well. A little bit about our room setup, infrastructure, and the facility within the ICU. What are the infection control measures that is in place, especially with the ramp up needs for COVID, as what Prof. Tu has shared. I think globally with COVID-19, we can see a greater compliance in terms of infection control practices, which is a good outcome. I will also share in terms of ICU key performance indicators. What do we track in ICU? What are the ICU bundles that complement the indicators that we are using? And with COVID-19, we have also managed patients with prone ventilation. Yeah, I will share a little bit on the protocol that we have in place in managing prone ventilation for COVID-19 patients. And last but not least, I'll cover on manpower augmentation. As we know, worldwide, we are short of healthcare workers, and with the Omicron variant and previously the Delta variant, many of healthcare professionals are in fact hit by the COVID-19 as well. All right, this is a picture of the intensive care unit at my hospital. We have 2 units, which is identical, similar to what you see here. So if you walk in from the visitor entrance, this is the view that you see, right? It is a very big corridor because we facilitate rounds for our clinicians, nurses to do their work. And we also have very active movement of patients on their bed to transfer for procedures as well. All our patients are in fact managed in a single room, as you can see from the picture. And infrastructurally, all these rooms are negative pressure, right? And this, in fact, give us the flexibility for us to manage airborne cases. In fact, with the facility available, it facilitated us to manage our COVID-19 patients as well. A closer look in the room, as any ICU beds around the world, I think is rather familiar. We have definitely a patient's bed. We have pendants where our medical gases are linked, our patient's monitor, and enough circulation space, yeah, for us to manage patient with ventilator, dialysis, intra-aortic balloon pump, or even an ECMO support as well. Okay. This is a view of another room, yeah. And if you notice, we always have a good sense of orientation of day and night to the natural view outside. Yeah, so our patients will have a sight of daytime and nighttime. Okay, a closer look at the infrastructure build-up that we have set up a lot of connectivity so that all our devices, as you can see from here, dialysis, volumetric pumps, a ventilator, intra-aortic pump, these are all connected into our system, and we are on fully electronic system. This will facilitate our monitoring, nurses monitoring as well, documentation, as all the readings of the machines and the patient's reading are in fact interfaced into our electronic medical records. Okay. A closer look on managing a patient on a mechanical ventilator. Okay, this is in fact a diagram just to illustrate what I've shared on the view of our ICU. If you notice, it's definitely a single room. We have a pendant in place with all the monitors and availability for us to place all the life-sustaining devices to support patients. And over here, because of the single room, we have also built up an infrastructure that we are able to monitor or adjust the patient's monitor without the need for us to enter the room. Alarm management, yeah. We have this recess area here where nurses, doctors, respiratory therapists are able to in fact monitor patients directly, yeah, from the view along the corridor. And this is an alarm system that we are in the process of installing so that we have audible alarm. As you notice, our ICU is in fact quite big. We have 20 beds in each ICU. As with the shortage of medical and nursing manpower, the alarm system is in fact very helpful for us to manage our patients. This is a corridor that you can see earlier. This is just a diagram to show you our setup in the intensive care. We have 2 main corridors. Yeah, this is where the nursing station, where you saw the first picture when you stand into the ICU, and this is a setup. We are not a very new hospital. We are at least 11 years. We have operated for 11 years. Yeah, KTPH has operated for the last 11 years plus already. As healthcare is getting more and more demanding, definitely is very stressful for staff. definitely for the next of kin family members as well. We are fortunate that our hospital is in fact located next to a beautiful pond. So while our nurses are working, family members are visiting their loved one, they do have a therapeutic view to the environment. So you can see this is another picture where my cursor is. This area are in fact the intensive care unit. So it is specially designed to make sure that they give a maximum view to the external as a therapeutic healing environment as well. With COVID-19, in fact, the world is battling an unseen enemy. Yeah. So COVID-19 is one of the greatest infectious disease challenges in the recent memory as well. And you can see on this slide, surrounded by all the staff wearing the required PPE to ensure that they are safe. And all healthcare workers in Singapore, they are mask fitted with N95 to make sure that first, they are able to take care of themselves first before they can manage the patient. I would say Singapore is very fortunate. We have adequate supply of PPE for our healthcare professionals to manage the demand of COVID-19. Another aspect is the safe environment that we have in the hospital. We do have rostered routine testing, even the healthcare professionals, support staff, admin staff, they undergo routine testing of ART. We started with PCR and eventually we evolved into ART testing as well. Some environment perspective to share. We always keep our guard up. We do have posters. We do have communication in place, like we no essential interaction, no mask off interaction, no social gathering while we perform our duties, because we need to be mindful and we need to track to ensure that our staff numbers are not hindered by COVID-19. Hence, we need to take necessary precautions. As you can see, they're having meals, is not sitting all together. We have shield build up depending on location. They eat, no communication while mask down. And if you need to communicate with your colleagues, you need to be on your surgical mask minimally. In view of the high volume of required patients, the ICU beds that we have in the high hospital is not sufficient for us to support the demand nationally as well. So every acute hospitals are tasked to expand the infrastructure of the ICU to support Singapore national demand as well. As you can see in this picture, where my cursor is, this is in fact a post-anesthesia care unit. So we have converted this even to manage patient on mechanical ventilator in the peak of COVID over in Singapore. This picture here, this is in fact a general ward, isolation ward. But of course, during the hospital planning, when we build this hospital, we do have a backup of expansion plan if need arises. So 11 years into operation, the need arise at our doorstep with COVID-19. Hence, we have converted one of our 14-bedded isolation general ward into an intensive care unit. And we are still operating this location as a backup ICU until today. Yeah, until today. So with the critical expansion, of course, the challenges will be staffing. We need to have massive rapid training, setting up work processes, conduct briefing, required training, skills and competency. Because these are not locations that we manage ICU patients for business as usual, we have to look into infrastructure. We look into IT capabilities to be connected, and we honor our staff. Staff engagement is something that we conduct all the time. We evaluate, and also we look for process improvement along the way. Insights from the inside as well. As you can see the picture over here, this is one of the first COVID patients who require ECMO support at Khoo Teck Puat Hospital. You can look at the amount of people that is involved in inserting of an ECMO catheter as well. And all the nurses are in fact on a PAPR besides a full PPE and N95. This is a conversion of one of the isolation ward into ICU. There is no difference. You can see from the picture, this is in a ward that we have converted. We are able to manage continuous renal replacement therapy. We are able to manage patients on mechanical ventilator and on various inotropic and sedation as well. This is the corridor in the isolation ward, which we have converted into an intensive care unit. This location is also negative pressure. With NT room as well. So along the two corridors on the right and the left, this is where the patients are located. And our greatest challenge to convert this is definitely a nursing manpower. Yeah, because we need to ramp up the capability of staff to be able to manage high acuity care. As we ramp up at the surge of COVID, our staff in these locations, while they are on duty, you can see they are in fact on the full PPE, including goggles and shield as well. For infection control practices, I think we have benefited earlier from earlier sharing from Prof. Tu as well. I would just like to reiterate the same basic fundamental that we adopt over in Singapore on hand hygiene practices. Yes, we do see greater compliance. I think it's same across the world. Full personal protective equipment, PPE, is something that we are fortunate. Many areas around many countries are running very short of PPE at the peak. And definitely we also need to manage, we need to conserve the use of PPE, we need to mitigate the risk as well. And mask fitting, yeah, all staff in the hospital are mask fitted to ensure that they are fitted with appropriate N95 masks. Of course, workflow and also various transfer routes as well. You can see on this picture, this is how we conduct mask fitting. We will spray a device, we will make sure that they rotate their head, look up, look down, and inhale and exhale. If they are unable to taste the bitterness of the solution that we use for mask testing, then in fact, the mask is actually suitable for the individual. Yeah, so everybody will go through a routine mask fitting. And the hospital do carry various type of mask, N95 mask, as you can see from this picture. Yeah, N95 mask you can see is of different types because not everybody can fit a unique size or unique type of a mask. This is the one common poster that we still see until today. We can conduct training, we can conduct briefing, but we also need to make sure that we make it visible prior to staff entering a patient's room as a gentle reminder that they need to wash their hand, have they put up the N95 mask, goggles, hairnet, long sleeve gowns, fluid repellent, and also gloves. So this is just a backup check before they enter the patient's room. Okay, over here, this is where the ICU nurses, you can see they are all on full PPE, and before they enter the room, they are reminded what they need to put on. Over here, you can see there's an airborne signage as well, the one that I show. So this is make it visible for all healthcare professionals, not only nurses, doctors, but we have RT, we have physiotherapists, we have dietitian, we have pharmacists moving around, carrying out their duties for the patients. At handovers, in a conference room along the ICU corridors, I think care is, in terms of PPE, is not compromised as well. Our staff are on full PPE on their goggles, N95 masks, gloves, while interacting and communicating. As we know, the Omicron variant is highly infectious. It can easily be transmitted. Hence, we have to take a maximum infection control practices, even interaction among staff. They have to be on full PPE at a clinical area. One aspect that is very important in terms of cleaning, turning around beds, cleaning up the corridor each time after a patient, a COVID-19 patient is transported, so that there are no traces left behind. We minimize the risk of cross-infection for the next available personnel, patients that is walking through the corridor. Hence, you can see our environmental services staff is in fact very busy in the last 2 years plus, cleaning the environment in the hospital, cleaning the bedside, even the toilet, surfaces, cardiac table, and within each cubicle as well. So this group of staff has been very critical in supporting the healthcare system, yeah, and also to minimize the risk of infection. My next sharing, I will bring you through some of the ICU key performance indicators that we monitor at KDPH. Things that we monitor include nosocomial methicillin resistant Staphylococcus aureus, in short, MRSA infection rate, right? Over here, I have put down a table of 2021, and you can see the MRSA rate has improved tremendously. Yeah, we do have one in 2019 prior to COVID. Then 2020 we are doing fine, and 2021 I must say that we are also doing very fine in terms of MRSA infection rate. I think very key basic to sustain this is simple things like hand hygiene. Yeah, hand hygiene practices, good infection control practices. Central line associated bloodstream infection, CLABSI in short, is something that we monitor as well. We do have, because our patients are very sick, they come in with multiple comorbidities as well. And from the chart here, you can see in 2019, this is the one in blue, number of cases, 2020 and 2021. We do have pockets of cases in June, October, where COVID in fact has started. So how do we track all this? We monitor the infection control, infection data rate. Each time we have a case, the ICU supervisor will have to discuss this case in detail with our pharmacies in terms of antibiotics usage, antibiotic stewardship as well, plus the ICU directors. They will sit down and review the case in detail to review whether is this preventable, is it hospital acquired, and how can we learn from each of the cases that has sustained a CLABSI infection. Catheter-associated urinary tract infection, COTI data, is we are monitoring as patients are on catheter. So they are COTI bundle that we are using. In fact, all the ICU data that we are collecting, I will be sharing with you a snapshot of what are the bundles that we put in place, what the nurses are doing, what we need to do before each procedure, like catheter insertion. Yeah. VAC, a ventilator-associated condition as well. Because in view that the patients are sick, they are required on a broad spectrum of antibiotics. You can see we do have VAC data across the months. Yeah, and these are in fact when during COVID, and this is the data that we're monitoring. But nationally, we also have to do some benchmark with the rest of the hospitals in Singapore as well. We are not far from the national benchmark. In fact, we set a stretch goal for ourselves. Our target is in fact 0. So it's a continuous learning. We are still working very hard to bring the infection rate as low as possible. IVAC is the infection-related ventilator-associated complications. Yeah. So this is our 2021 data as well. So we always monitor over 3 years. And after we get our data, we monitor it against national data. Possible ventilator-associated pneumonia. The number is not high, but we are also monitoring, and we do have intervention that we put in place how to minimize ventilator-associated pneumonia for those patients on mechanical ventilator. All right, so this is what I meant. VAP, we have a bundle. This is what VAP bundle looks like. We start the patients on, we elevate head of bed elevation of 30 to 45 degrees. If not, then contraindicated, DVT prophylaxis, stress ulcer disease prophylaxis, daily sedation weaning, ventilator weaning, and most important is also glycemic control. So we have this bundle in our electronic documentation to make sure that these are not missed out. It's not left to chance, and this will be done by the nurses as part of the workflow sheet every shift, and also will be reviewed by the ICU team during the rounds minimally twice a day. For DVT prophylaxis, this is our intervention. Okay, SCD, CAT stocking, chemo prophylaxis, whether yes or no, if not, why, so that no single patient will be missed out from the bundle care that we have actually put in place to minimize all the risks that for vulnerable ventilated patients. Stress ulcer disease prophylaxis, again, the checklist will be done. Yes, no. If it's not applicable, if it's contraindicated, it has to be documented. For sedation weaning, we do try to sedate those patients, to wean off the sedation of those patients who are ready to be weaning off, in order to extubate them at the soonest possible time. Yeah. Ventilator weaning, and this is a very important aspect of care. This don't happen only in our intensive care unit, in our general ward as well. Catheter-associated urinary tract infection, you can see it's listed here. Hand hygiene, okay, apron gloves, maintain closed drainage system. We need to perform a perineal meatal hygiene. How we position the urinary bag, ensure the correct anchoring of the urinary catheter, and the urine bag should not be more than 2/3 full, yeah, because this is to prevent the risk of backflow of urine while the patient is on urinary catheter. So these are in fact very simple measures, not extraordinary, that can be easily achieved to minimize the risk of catheter-associated pneumonia infection. Central line bundle is very common for us in the intensive care unit, for us to manage administration of medication. So bundle compliance, yeah. Before each central line insertion, we do a timeout. These are the questions that we run with the team, meaning the procedurists, the nurses who assist the patient in this procedure, assist the doctor in inserting a central line, hand hygiene before procedure, a checklist, optimal catheter site are considered before we even approach a subclavian, yeah, because subclavian approach do have a greater risk for some complications as well. Antiseptic skin prep are done appropriately, barrier precaution, patient's barrier precaution, provider barrier precaution, and once it's inserted, if it's inserted out of the internal and external jugular vein, then there is a reason why we are approaching a non-standard site for the catheter. That's all about our bundles that we use. And we also have a quality indicator board that we make it very visual for our staff. You can see here, daily report of a device-related nosocomial infection. What I shared with you is residing in the intranet, is residing on the file, but this is make it visible in the intensive care. Anybody who walks in, they can see the data right immediately. Yeah, and again, a gentle reminder on 5 moments of hand hygiene prior to any healthcare professional entering the patient's room. You will always see this. Yeah, 5 moments of hand hygiene. So it's again visual. It's again a gentle reminder, peers reminder as well. Back to the ICU environment, you can see this is a trolley set up in place since COVID. These are made available for staff to use, and to decontaminate gowning, doffing. And this is the preparation before they go into the patient's room. They will check each other to make sure the gowns are properly secured, PPE are properly worn before the team go into the patient's room to attend to patients. This is another view outside. You can monitor the patients very visually. And this is a picture of our first COVID patient requiring ECMO support. I think over the last 2 years, we do have multiple cases with ECMO support. And although these are the first case that we have, we managed to secure an ECMO catheter, stabilize the patient, send the patient to the national center, and we are proud to share that, in fact, this patient walked home. The patient managed to walk home and go back to their normal life. And of course, we go through rehabilitation of that. So this is indeed our first ECMO patient at KTPH. And you can see, after we insert, we stabilize patient, we need to transfer the patient to a national center. This is where the patient, the amount of healthcare professionals that's accompanying the patient, and our environmental service colleagues, immediately they clean up the environment. So we really try our very best to minimize the risk of cross-contamination that's left behind after a COVID-19 patient being transported through the corridor. With COVID-19, this high flow nasal cannula, HFNC in short, has emerged as one of the new modalities for us to manage COVID-19 patient. It's a treatment modality that we hope not to intubate patient. We do have a considerable number of patients that is able to tie through this non-invasive high flow nasal cannula without the need of intubation. And with this, again, we have to set up new processes. We need to train staff, briefing, how do we document, and we are also learning in our journey how to evaluate and process improvement along the way. Prone ventilation is something that we have done very frequently. It's very labor intensive. If the patient is ventilated, we need at least 6 healthcare professionals to safely turn the patients. And of course, over time, we've also established some protocols, evidence-based protocol, what need to be done before we can perform a prone ventilation on patient. This is just a print screens to show you. We do have a checklist of prone ventilation, initiation phase, how do we do, how do we evaluate, so that every item is not missed out. Yeah, example, we explain the procedure to the patient and the patient's family as well. If the patient can comprehend and is not sedated or paralyzed, a prescription of sedation, we use rest score, a B-stag target as well, train of 4 for once per shift while the patient prone if the patient is on a muscle relaxant. Then of course GCS, we establish that, and prior to turning ETT, we make sure that catheter is in place. If the patient is on a dialysis, then we will need to temporarily pause the dialysis while we prone the patient, because it's quite challenging for us to prone and dialyze the patient because the catheter is always located at the groin most of the time, so we need to discontinue for a while. And we need to aspirate the nasogastric tube prior to the prone position to minimize the risk of aspiration as well. And nursing care are paid to bony prominences as listed in the bullet point to make sure that it's all well supported and there's no risk of development of pressure injury. Eye care, as I mentioned, interruption of renal replacement therapy, and we have to stand by emergency trolley as well while we perform this prone ventilation as a patient may suddenly deteriorate. Yeah, endotracheal tube, oropharyngeal suctioning, and we do pre-oxygenation. What are the requisite? Manpower required, 6 staff. If your chest drainage is present, then we need to be very careful. We do not want the tube to be dislodged as well. And we will reposition the electrode so that the patient do not lie onto the electrode that cause pressure for the patients as well. So a prone ventilation, it may sound very simple, but there is a tremendous effort and also checklist that is in place before we can carry out a prone ventilation. So this has become a norm in the intensive care now when we manage COVID-19 patient. These are some of the pictures. You can see the patients are surrounded by life-sustaining devices, intra-aortic balloon pump, dialysis, ventilator. This is at our ICU. This picture is in fact at our ward, isolation ward, which we convert into ICU. You can compare side by side. The equity of care is similar. Yeah, it's similar. Transporting patients, we also need to do drills, how to transport patients safely. And there are so many lines, patient is very sick, and how to make sure they degown when they come back after they transfer the patient to make sure that there's no risk of cross-infection as well. Manpower augmentation, I think across the world, there's shortage of nurses. There's a need for us to ramp up ICU, but we do not have enough ICU nurses. Hence, we have cross-deployment, cross-training, rapid training of our general ward nurses to give them some skills, ICU survival skills, as soon as possible. And of course, they are not left alone. They are buddied with our ICU nurses. And that is where the new challenges in place, but we have no choice. I think with COVID-19, we have learned new ways of managing demand. And nevertheless, having said that, we have to ensure that care for our patients remains safe. Yeah. You can see this is one of my ICU staff, 2 of them. They are in fact training all the nurses that we are going to deploy in to help us to ramp up how to use Jupiter, how to test, how to make sure that they are safe when they use this apparatus. I do conduct briefing very regularly to address the safety concern, and I'm sure healthcare professionals are equally concerned with COVID-19 as well. So safe and secure access to the hospital premises is something that the hospital look into as well. We cannot stop people from coming in. You know, we have dying patients, we have very sick patients, but we do our level best to make sure that they're safe before they come into the hospital situation. As I shared, it's very stressful. You can see from the inside of the hospital, but we always remind our staff, we do have a nice environment. We need to take time to pause while having your meals. You need to look out, you know, to recalibrate your stress before we can continue this long marathon journey of COVID-19, which is still ongoing. So in summary, my sharing, these are the 7 pointers that, you know, in whichever processes, new services or expanded services that we need to do, we will run through this checklist: setting up of structured work processes, effective communication, training requirements, infrastructure and IT capabilities. This will facilitate monitoring as well, staff engagement and feedback, and of course, patients, we do listen to them, patient experience and feedback as well. And once we have 1 to 6, we will evaluate all the processes and we see how we can improve as we go along. We have changed many work processes along the way, yeah, and we will tweak based on real situation and experience that we have on the ground to make sure that workflow are in fact simplified for our staff. Care philosophy, we want to provide care which is good enough for our own mothers. We listen, we offer help, we give value, and we engage patients. So these are the care philosophy that we adopt in our campus. And now in Singapore, we are learning to live with COVID. We are transiting a pandemic into an endemic situation. I must say that it's not easy for everybody, whether it's healthcare, the public, or even school children in school. We have gone through an unprecedented time. It's very challenging for everybody, but we are hoping for a better tomorrow. Yeah, and what we learned in these 2 years plus, we've put in place, and we need to live a new normal situation. Yeah, I think this is one of my last slide, just to show you that we try to create a healing environment in the hospital so that I think it's therapeutic. It is able to bring down some of the anxiety or even your heart rate and your blood pressure as well. Not all the time, but at least a transient episode as we move along this challenging journey. Yeah, this is my last slide. I'm happy to take any questions, and I has indicated my email here as well. If you do have any further questions and you want to clarify, you can also drop me an email. Yeah. Okay, thank you very much. I will stop my sharing here and I will hand over to the chairperson. Yeah, thank you.
Thank you, Ms. O'Reilly. Your presentation is so wonderful. I see that from the presentation that the environmental area of the ICU in your hospital is so ideally, very ideally for all the patients and also healthcare workers. Yeah, because about the responding to the COVID-19 in the presentation of Professor Tu also say about that hospital, we need to have a patient flow, the touch-free air opening. But in Vietnam, it's very, very difficult for hospital, old hospital in the big city like Ho Chi Minh City or Hanoi capital. So it's not easy, and also expenditure is a problem too. But in Singapore, I see that the your hospital, the big area and also isolated room is so good for a patient. The patient can see the outside scenery and also can enjoy the fresh air from outside, etc. Yeah, yes, and now this is for the Q&A period. So everybody, please give your questions to our speaker, Professor Tu, and also Miss O'Reilly. Yes, they're waiting for questions. Now, until now, I have I received some questions for both of you. Yes, firstly, questions for Professor Tu. Yes, may I start, Professor Tu?
Yeah.
Yeah. The first question is, you please give the advice for practice when people go out and get back home from the outside. How do they do in order to decrease the risk of COVID-19 for their relatives in the home? Yes, the first question.
Yeah. So thank you for your question. So your question is about the like infection control for the community. So many people also ask me that how I go out very often. I come to work, and after that, when I come back home, how can I how can I protect our relative or something else? So very difficult. You know that we had a very experience that many health doctor and nurse, when they work in the hospital, they haven't got any COVID yet. But after that, when their children come to school, and then their children come to school, and then they get infected at home, not in the hospital. So in the family very difficult, because we had a close contact, and very difficult to prevent. But we still had the method to prevent. So after you go back home, and before we go home, enter the room, we need to clean the hand. It's very simple, like simple, clean hands and still wearing mask. And if you are you think that you just meet with the people that can be infected something, you need to change that your clothes immediately and go to for the shower immediately, and before you can contact your relative. Yeah. And if you think that you are already infected something, you need to be isolated with the other immediately. So you need to stay in the room and use in the private room with the private WC, something like that. Yeah.
Yeah. Thank you for your advice. Yes. And the next question. Please give the advice for people who receive food goods from shipper, like they buy something online, yeah, and how to prevent to acquire COVID-19.
Yes, many remember that during the high peak, so there are many ways to prevent the infection from the shipper. So normally the shipper, it's better that they just put the food or the goods something in front of the house, and they can leave if you already pay for online, something like that, so that you don't need to contact with the shipper, because shipper always contact with many people and the risk of infected is high. So if you like to limit it to contact the shipper, you need to pay online first, and then when they come, they just put a good in front of your house or your apartment, and then they leave. And then when you open your house and apartment to get the food, some people recommend that we can spray the outside. Is it okay? If you like to spray it like disinfection, spray the cover, it's still okay, but you need to use the alcohol only. You cannot use the other chemical, because the other chemical can disinfect it, but can make your food, for example, become dangerous when you swallow. So only alcohol is safe for the disinfected outside. But I think the more important that you remove the outside before you bring the food or the wood inside. This is important. Yeah.
Yes.
Yeah.
Thank you. Yeah. Thank you, Professor Thư. Yes, your answer is everything for everybody to be applied. Yeah, in their lives now, because now we are living with COVID-19 already, and this is it's very practical that when the children get to school and the COVID-19 pandemic is spreading everywhere. Yes, and the number COVID-19 acquired is increased every day. Yeah, and now this is program for.
Can I add more one information? As you already hear from Miss Ori, that Singapore now they plan to change from the epidemic to the endemic. So Vietnam also do the same thing. We are waiting to see if we have any new variants. If we don't have any new serious variant, we also change that to endemic. So when we change the COVID to endemic, that means we tend to return to everything to normal. So so now Ministry of Health Vietnam now is will publish the new guideline for the COVID-19. For example, we will abandon the medical registration. We don't do the screening test for every patient to come to the hospital anymore. And then we try to ask the people to keep the infection control basic like hand hygiene and mask and everything. Yeah. So you maybe receive this this on the new policy maybe in next week something. Yeah.
Thank you for good information from you. And now we concentrate on the ICU area, ICU for COVID experience from Singapore. And now some questions for you, Ms. Orazor. Yeah.
Yes, go ahead.
Yeah. Firstly, in general, I see that in the ICU, in your hospital, that every nurse sitting in front of the room, the isolated room. So how many nurses in your ICU and how many beds in your ICU?
Thank you for the question. In our ICU, as I mentioned, we have 20 beds. Yeah, so when we are 20 beds ICU, 20 rooms, yeah, so one patient in one room. When we are hit with pandemic, we don't have the luxury of staff, and nationally in Singapore, we have also calibrated the nurse-patient ratio for us to manage ICU because we have to ramp up, hence the ratio has to be adjusted as well. In a normal situation, in business as usual, ICU, we have 1-to-1 or 1-to-2, depending on the acuity of the patient, how many life-sustaining support that the patient is on. So generally, when we are hit by COVID, minimally, we are average as one nurse taking care of 2 patients. So you can imagine the patient workload is very high and the nurses are in fact very stressful. Yeah. So one registered nurse cover minimally 2 patients.
Yes, yeah, thank you. And how about the survival of patient intubated in your ICU?
All right. In terms of mortality, I think generally, I give you an overview of the Singapore first. Yeah. So as we are speaking now, in terms of number of ICU patients nationally, okay, nationally in the entire Singapore, from the statistics that we have, the number of ICU cases stand currently is not high. I would say it's not high. Firstly, the whole nation now, we have about 28 patients in the ICU with COVID-19, 28, which is very low. Yeah, I think the fact that why we are able to have a low number of this is because Singapore has aggressively encouraged COVID vaccination. As of now, 95% of the population, 95%, in fact, are fully vaccinated. Yeah, fully vaccinated. So as of now, 28 is in the ICU nationally, requiring oxygen supplement, including general ward, is about 100 of them as of statistics as of yesterday. So in our hospital, as now we stand COVID as about 3 to 4 ICU cases, average about 3 now. So it has gone down tremendously. Previously, we have up to 10, 12, 15 each day. So for the mortality, it is not high, I would say, not much of a difference compared to our ICU mortality rate. As I think Prof. Tu has mentioned earlier as well, they don't die of COVID-19. In fact, they die of other comorbidities that they have. It's a disease process of the medical condition that they have. Yeah.
Yeah. So thank you for your answer. And now some answer in the Q&A room. So may I read? May I read? In Singapore, the question from Lê Chi. In Singapore, with disinfection, does hospital use for dirty surface? Yes. This is
I think generally we use sodium hypochlorite. Yeah, I think which is commonly used across as an infection control solution for us to do cleaning surfaces, all that. So it's basically sodium hypochlorite, and we make sure that we use disposables, disposable wipes to clean up, and we allow the surface to at least clean the room. It has to be dry a good 15 to 20 minutes before we can put the next patient. So the room must be properly terminally disinfected. Yeah, I think when we talk about cleaning a room environment, it includes the curtain, patient's curtain as well. You know, the curtain that we draw, all the surfaces, minimal items. Even we have a patient down there, we do clean our BP cuff with alcohol wipes. Yeah, with alcohol wipes. If we use devices, our mechanical ventilator, we use cleaning wipes as well, which is definitely non-corrosive to our medical devices on all the surfaces within the patient's room.
Yeah, thank you. Thank you for your answer. And now, next question.
I think that interesting more about disinfectant. What kind of chemical disinfectant that you use in the Singapore?
I think generally, as I mentioned, is sodium hypochlorite base for cleaning of the floor. Yeah, cleaning of the floor. But for surfaces, we use a methylated spirit of 70%. Yeah. Even for stethoscope, we have each stethoscope in each room in the ICU. We do not encourage clinicians to bring their own stethoscope. So after each use is wiped down with the methylated spirit wipes of 70%.
Yeah.
Yeah.
Yeah. In ICU of Vietnam, the telescope is 1 for 1 bed. Yeah. Thank you. And now next question. A patient with COVID-19 positive and after become to negative, and how long that when they become to negative, they can under the program operation. There is a problem in the body. They need to perform the operation by doctor.
Okay.
And how long? Yeah.
All right. We basically base on medical needs. All right. I think the criteria evolve over time at the peak and even today. So generally, I can share with you, if we have a patient who present at our emergency department, every patient will receive a baseline PCR. Okay, you will receive a baseline PCR if you are admitted to the hospital, right? So we'll take a PCR, and of course, the PCR will take, even a rapid PCR will take 4 to 6 hours to be available, the results, right? So if the patient require emergency surgery, we will still proceed to the operating theater to have the emergency surgery conducted. However, in the process of an emergency surgery, of course, the medical personnel who attend to the patients will be on full PPE because the status of the PCR is yet to be determined. So during the procedure, perhaps the result is out. If it's negative, then good for everybody. If it's positive, not an issue because we are already practicing maximum protection with PPE. So we have few categories. If the patient PCR status yet to be determined, so we are on a full PPE. If the patient already have a PCR status and is scheduled for surgery, then it's a lower risk. Yeah, it's a lower risk. Then we mitigate as we move along. Yeah, so what happened is, let's say the patient is admitted to the ICU. ICU stay can go beyond 7 days, can go beyond 5 days, right? So we do repeat because step down, we also have area general ward that is for COVID patient and general ward which is for non-COVID patient as well. So a very routinized PCR is done either at day 5, day 7, depending on the progress of the pandemic situation in the country. Yeah, so we received direction from our Ministry of Health, and this is standardized across everywhere. But as long as it's not been determined, the patient is high risk clinical assessment, we will practice maximum PPE when we are attending the patient. If the patient need to go for coronary intervention, the patient will proceed despite of COVID-19 status. Yeah. So we save the patient first.
Yeah. I think the question would like to ask about the elective operation.
Elective?
Yeah, elective operation. I mean, they like to if the patient had a positive COVID-19, and how long they need to wait for the elective patient.
Okay, so for the elective surgery, I would say that we also categorize it to urgent, semi-urgent, those cancer-based, of course, that we have to proceed. If and all cases that come in for elective, it will schedule on clinical needs. And before they proceed, they will have we perform a PCR swab for them or an ART swab as well. Yeah, so whether it's positive or negative, as long as they are high risk, they require surgery, we will proceed with the surgery. And I would say that like cataract surgery, right? Cataract surgery is something that is non-urgent. Perhaps for that, if they are positive, then we will have to wait a while until they turn negative. So our national protocol as of now, day 7 at 12 noon, you will be discharged. Means you are no longer infectious to others. You see, so the duration of 7 days is a general national guide over in Singapore now. Day 7. Yeah.
Thank you. Actually, in the CDC guideline, they also said that if you are got the COVID-19, for example, at home, and now you would like to get the operation, so you can go for operation when you are recovered. But how is the definition for the recover? So nobody say how does it recover from COVID-19 because we had a long COVID also. So that way, when in our hospital, we advise the patient that when they feel everything be healthy, they don't feel tired, or they feel everything is returned to normal, so we can apply for the elective operation. Yeah.
And for all the elective cases, they do have a hotline to call in as well to check with us. In fact, you see, if your appointment has been rescheduled, if you're unwell, you please call us. Then we can do a teleconference, in fact, to assess the clinical condition before we decide the next step.
Yeah. And when I asked you, you just told me that if the patient negative in the ICU, somehow you said that after 7 days you repeat the test again.
Over here currently what we do is that we have a routine test for all the inpatient that is warded, okay, whether you are general ward or whether you're in the ICU. We do one on admission, all right, that's one test. Then we repeat one on day 5.
One on
day 5. day 5. Then we have another one on day 8. All right, but this is just a general guideline. But in the event, if from day 1 to day 8 in between there are clinical symptoms, they are unwell, we are highly suspicious that they may have COVID infection, it's a judgment call that we'll proceed with the necessary PCR or ART as of now.
Yeah. Actually, but I asked you because in Vietnam we also do at day 7, but now we are in discussing that we will don't do any test.
Correct. Same approach over here. We are also scaling down. Previously, we do day 3, day 5, day 8, day 12. You know, so after that we do day 5, then maybe later. But we are also in the process of eliminating the need to test because it's already, we are transiting into an endemic situation. And we know from studies that Omicron is not as fatal as the Delta variant as well. And nationally, 95% of the population has been vaccinated in Singapore as well. So we are also scaling down the need of surgical masks in an open area outside, in a public area. In fact, the ministry has just announced, I think effective on 28th of March, outdoor activities, you no need to don mask, but you're still encouraged to wear mask. But of course, indoor, but for healthcare facility, we need to take slightly higher approach, to make sure that there's no transmission at work. But I'm proud to share that, we do very aggressive contact tracing on staff, on patient, to determine whether the transmission occur in the hospital setting or out of hospital setting. I think as a healthcare professional, it's our responsibility that, we do not pass an additional infection to the patient during hospitalization.
Thank you. Thank you for your answer. And now, one question for Professor Tu. Yes. In this new normal period, wearing a PPE in the screening area, in the COVID hospital ward, and in the sterilization room, how can healthcare worker wear these PPEs correctly? Yeah.
I don't know if I understand the questions clearly. So that is that the question asks about how to wear the PPE in the screening sector and in the sterilization sector. Yes.
Yes, for healthcare worker.
For healthcare worker, yes, sure. I think in every county they had the public their own policy for PPE use. In Vietnam, the policy for the PPE already public and already explain very clearly where in what situation we need to wear what PPE, something like that. But I told you before, we are planning to publish the new policy for the PPE maybe next week. So in the screening, for example, before we ask to use the full PPE, but now we will ask no need to use the full PPE anymore. So maybe you just only use mask and the face shield, and that's it. And so it depends on the risk that you think. You only need to wear the full PPE now, just only in the ICU, for example, when you do the procedure, the high risk procedure or something like that. Yeah. For the sterilization room, for example, in the CSD, you still can use like the standard precaution, because when you wash the instrument, so the instrument it can be infected your face and also your body when you wash them. So that's why you need to wear the mask, the face shield, and also the apron or something like that. Yeah. And even with the non-COVID patient, you need to wear something like that when you do the high-risk patient. That is the standard precaution. Yeah. So now we will publish the new PPE that will be will be more flexible for you.
Yeah, thank you for your answer. I see that it's so clear. It's so clear for healthcare worker in the new normal period now. No need to wear PPE in the screening area. Yeah. Yes, but we need to do. We need to do the compliance like a 5K. Yeah, in everywhere. Yeah. So now it is the time for ending the program, and I see that yeah, we are very happy to receive lots of questions. Yes, and receive the answer from our speaker.
Yeah, can I just add on something? I think earlier one of the participants did ask the specific disinfectant that we use, right? So it's, as I mentioned, the base is sodium hypochlorite, but I think the chemical name is that we are using quaternary compound, quat. We use quat for cleaning, yeah, for services. And on top of that, we have also started using UV light. Right? It's a robot. We can bring it to the room. Then we can, on top of all these, using quad to clean, we use UV light as well. So in the general setting, besides the ICU, in the wards, where the toilets are shared by patients, they walk in and out of the toilet. So we also are using UV light as well. Yeah.
Yeah.
So you had a UV light at the robot, right? And then
yes, for cleaning, I think that will take up, of course, after the general terminal cleaning, we leave it about 15 minutes, and this will zap out everything.
Yeah. Thank you. Because in Vietnam, in guideline we usually use chloride, but we found out that chloride can be make the corrosion. Before,
yes,
yeah, we also use quat, and let me for the Vietnamese people. So in the quat in Vietnam we also use like for example we use hexaniol or cypraniol or something like that. That is quat, but because the guideline to make the chloride for everybody for easy, so sometimes people very curious that maybe in Singapore we use something else that we better.
And on top of this, for the environment, we have, as a hospital, I think it has given us an opportunity to innovate. We have also created UV boxes at every clinical location where you can throw your phone, your handphone, your pen that you use, your goggles, you just throw in for 5 minutes. It's a UV disinfectant. And we have done and follow up, and we have taken swab after the UV box, after we put our items. Even all your accessories, your little pouch, things that you carry along yourself, your handphone, you can actually wipe out almost 98 to 99%. So this is an innovation that we have done. So if you want to, if you want to have more details, I'm more than happy to share with you offline as well. Yeah.
Thank you. We are discussing about the UV box also, but some people ask the question that is it okay to put everything in the UV box, but because that thing is not clean. So it still has something like dirty or something.
Of course, before we put the item into the UV box, standard is that we still use the methylated spirit of 70% to do a wipe first. Then we throw inside.
Yeah.
Even your whole bag can be placed inside. Yeah.
Thank you.
Yes. Thank you for everybody joining in our program today. It is the valuable time from you because it is a weekend, but you are here from the morning until now, nearly noon already. Yeah, so yeah, please we say thank you to all of you to be here today, and thank you for our speakers, and thank you for everybody. Yeah, and now we are closing program here, and Very happy to see you in Singapore.
Thank you for having me.
Yes, and very happy to see you in Vietnamese in order our speaker can meet together.
Hopefully one day we can have face-to-face interaction. Yeah.
Thank you. Thank you. Goodbye. Goodbye, everybody.
Yeah.
Bye-bye.
Thank you. Bye-bye.
Nipro Corporation strives to realize our philosophy of contributing to society through our business. We take pride in creating the finest innovative medical technologies that improve the lives of people. Currently, we face an unprecedented pandemic, the novel coronavirus. To fulfill our responsibility to society, Nipro supports global healthcare needs by providing our innovative products to frontline medical professionals and the public. Our next generation minimized dead space syringes reduce wastage of vaccines, enabling more individuals to gain access to the vaccine. We designed a highly functional respirator mask with low inhalation resistance, high particle capture for efficiency, and easy breathing to ease the operation of medical professionals as well as those in need. Backed by research, our team developed an aerosol disinfectant as an essential added measure to reduce the spread of viruses and bacteria. Our fight to improve global healthcare doesn't end here. We will continue to push the boundaries of medical innovation to provide better healthcare solutions for everyone. Together as one, we will overcome the pandemic and improve global health. Nipro, your partner in healthcare.